Bateman, who is excellent. We're just hearing we're being recorded. Our speakers today are Fiona Bateman, who is an expert solicitor, independent chair to adult safeguarding boards, and one of the authors of the excellent multiple exclusion homeless safeguarding toolkit produced by the Voices of Stoke. We've also got Kendal Beasley, who is a homeless specialist nurse in adult safeguarding from East Kent Hospitals University Foundation Trust, and Shona Duffy, also as homeless specialist nurse with the adult safeguarding team with the Gloucestershire Hospitals NHS Foundation Trust. And really it's those two nurses who are the inspiration for this meeting. We were chatting before we started about how when the Care Act came in 2014, I personally was very excited to see that. It really seemed that the sorts of vulnerabilities that we saw so often with our complex homeless patients, simple practical things like difficulty handling money and difficulty maintaining personal hygiene, were grounds for getting social care involvement. But of course, it was introduced in a time of serious austerity, and a lot of that early potential didn't seem to be being met. But just of late, things really do seem to be changing. There is the guidance out there. We're speaking about lots of attention to this issue from local government. And what's really exciting, I think, is seeing nurses in hospitals within safeguarding teams. And it really does feel now like safeguarding is this sort of area of common understanding where health and housing, social care and the voluntary sector can come together around the individuals with experiencing complex homelessness to try and resolve their issues. So I'm really excited to be chairing this meeting and really looking forward to hearing from our speakers. Our plan is to hear from Fiona first for the sort of legal context, and then Kendal is going to be speaking about her work in Kent, and Shona will be speaking about her work in the Gloucester A&E department. So I think we're just about set now with all of our speakers. So I'll ask Fiona to start sharing her screen and take it away. While you're doing that, Shona, I'll keep an eye on people coming into the meeting and admit people as necessary. Thank you, Fiona, sorry.
Yeah, that's fine. I started sharing my screen and immediately lost the access to the mute button. Apologies, people. So thank you very much for having me. I have been asked to speak for about 20 minutes, but I suspect that the majority of you will want to hear more from Kendal and Shona. So I will try and be quick. The slides are there, the recording is here, and the toolkit is, yeah, I'm one of the authors, but actually the work was done by many other people, and they, it's excellent. It's really helpful in terms of getting that information together in one place to help articulate how to get access to the right help and support for people. So I can quickly kind of do a run through, if that's okay, as to kind of what we found and what might help in terms of articulating the way in which the safeguarding duty under the Care Act can really affect and help bring that multi-agency planning and protection together. I was saying to Nigel at the beginning that I came to this line of work, or rather I've come the long way around. I started as my career in working with Ross Sleepers. And the two things that pulled people into the day centre I worked in was a decent breakfast and a nurse, access to a nurse. I got quite good at cooking a fry-up. I never, ever, ever ventured close to having to do the nursing work for clear reasons. But I found myself as one of the people whose job it was to try and link people to available accommodation. Very frequently arguing or trying to explain to other statutory individuals, people who work for statutory organisations, why I felt they should be supporting the individual maintain or get access to support, and very frequently losing that argument. So I went off, trained as a lawyer, And as I say, I found myself back here 20 years later now, kind of saying how the law is beautifully designed for this cooperation, for this kind of multi-agency risk management, planning and providing support to individuals to help them access appropriate accommodation, but also accommodation-based care and support. The common barriers that we know about for effective interventions have been articulated better than I could by King's College, primarily the lack of cooperation, coordination, leadership, the lack of professional curiosity, or conversely, that normalisation of risk. If you work at the front line and you're seeing really high levels of risk all the time, actually it takes something quite extraordinary to kind of make you think, oh, and there's also a disparity among practitioners. As somebody who had no formal qualifications at all, but worked and understood the case history of somebody and understood what was preventing them from keeping themselves safe or getting access to, you know, basic things to manage their nutrition, to manage their medication, to manage their health needs. I found myself not really having a voice and not being heard. I got a law qualification, no more experience, but a law qualification, and people started listening to me, and I don't really understand why, but anyway. So that disparity continues, and actually it's partly my job now as a safeguarding chair to really kind of hammer home that needs to end, but also I think it's all of our responsibilities to really start thinking about whether we are actively listening to the voice of the individual that's in the centre of this, if we are adapting the way that we, you know, our usual processes so that we comply with the Equality Act, so that we comply with human rights obligations. And that's what I mean about the law being beautifully designed to really facilitate that multi-agency practice. But as Nigel pointed out, introducing it at a time of mass austerity and making us all fight over the tiny resources has limited the opportunities for those. There's also kind of you need to kind of think about that kind of, you know, the traditional routes for assessments really often don't work for this cohort. It's not easy for people. And this was brilliantly demonstrated by some work at King's last year or the year before maybe, where they looked at that kind of expectation that on discharge from hospital, somebody would be able to go to various appointments, often conflicting appointments at the same time, and you know, and that in itself can mean it that people aren't able to be in two places at once, and then because they haven't turned up for an appointment, they're then discharged from a very necessary service. The lack of suitable provision has, you know, been highlighted already, but also, and work that I do in safeguarding adults boards and as the SAR author, safeguarding adults review author, poor contingency planning, if you know, in terms of preventing escalation of needs, comes up so frequently, as does continuity of care. It is a safeguarding issue, so frequently becomes a safeguarding issue, but there are two kind of prongs, if you like, to safeguarding duties under the Care Act. The first one is the Section 42 duty. So that's when you have a duty to carry out an inquiry if there's an adult with care and support needs at risk of abuse or neglect and unable to protect themselves. I'll show you in a little while, you know, the slides that I have that kind of helps you talk you through the Section 42 duty. But remember, there's two aspects of that. Firstly, the obligation to meet the immediate need for protection, but also it can trigger that multi-agency response to help coordinate a longer term plan, even if that means through different processes, such as the Section 9 duty to carry out an assessment. There's also the Section 44 duty, which is when a safeguarding adults board has to arrange a safeguarding adults review if an adult in their area has died or has suffered serious abuse or neglect. If there's concern, partner agencies could have worked more effectively. And it is that duty that really has kind of, in my experience, or in, you know, what I've seen over the last couple of years, that has really kind of put, I suppose, coal into the engine of driving this kind of idea that actually we have got an obligation to safeguard those who have experienced multiple exclusion homelessness, and that actually we can't just carry on doing the same thing when we know it doesn't work. I've just given you some choice quotes, my favourite quotes from different judges in the court protection mostly, or under the inherent jurisdiction, but High Court judges who've been very clear that we should be moving away from that paternalistic approach to really thinking about how we support people understand their legal rights, identify situations where they might be exploited or experience coercive behaviours, help them make informed decisions about risks based on their views, their own wishes, their own belief systems, and then help that manage that risk in a way that is meaningful to them. I've also given kind of headlines there really around kind of what I mean by access to assessments and provision of accommodation-based care. For far too long, I think, homelessness has been seen as a Housing Act duty. And of course, there are obligations under the Housing Act for people to assess and consider somebody who's at risk or experiencing homelessness. But our statutory duties do not end there. Section 3 of the National Health Act is very clear that the NHS can provide accommodation-based care in its basic form. That's what a hospital is. But of course, hospitals are not designed as accommodation, long-term accommodation for people, and it's not a good place for people to stay. But there is also scope for, under continuing healthcare, for people to have accommodation-based care. Similarly, under Section 117 of the Mental Health Act, that might incorporate accommodation-based care. And Section 18 and Section 19 of the Care Act talks about a duty to provide accommodation-based care if somebody's in urgent need. So that can all be accessed, if need be, in urgent situations. When does a Section 42 duty, so this is the duty to carry out a safeguarding inquiry, start? Well, if there is a reasonable cause to suspect that an adult in your area, and by that we just mean they're physically present in an area. It doesn't matter if they're ordinary resident, if they have a local connection, if they're physically present in that area, then it is that area, that local authority, that leads on any safeguarding inquiry. Any protection plan might need to look at things like local connection and ordinary residence, because that might be relevant for kind of longer term, who's going to be responsible for the accommodation-based care. But ultimately, that immediate kind of, do we need to carry out an inquiry? What do we need to put in place for an immediate protection plan? Just need somebody who's physically present. You need to be able to show that they have a care and support need. But that's really widely defined under the Care and Support Guidance, which is a statutory guidance that goes alongside the Care Act. Paragraph 6.104 of the guidance, if you have to highlight it ever, and I hope you don't, but you might, talks about conditions linked to physical, mental, sensory, learning or cognitive disabilities or illnesses, substance misuse or brain injury. So you see how incredibly wide that is. If agencies, statutory bodies, because of duties under the Equality Act, must also consider whether they have to make reasonable adjustments in respect of their usual offer. And that's kind of, that's why Kendal and Shona have the jobs that they have, because that's it's so critical that we think about actually what's going to be needed for certain cohorts so that everyone can access the support that they need. And are they experiencing or at risk of abuse or neglect? There is no threshold of significant harm. You are looking just at whether it's because it's a preventative duty as well as a responsive one. So, and then that's deliberate because of that statutory obligation under the Human Rights Act to protect life, to act proactively to protect life that we all hold. And then that idea around if they're unable to protect themselves. So this is where often there is a real complexity for practitioners, thinking about actually an individual's ability to articulate whether they want or are in a place to accept support. Far too frequently within safeguarding adults reviews, we see that because somebody's been told, and if you'll pardon my colloquialism, to do one, that means that the person was considered to have capacity and that they were refusing any kind of support. This is not necessarily going to be able to kind of hit that, yes, you've hit your, you've met your duty of care. You've got to actively consider that those obligations under the Mental Capacity Act. Have you explained to the individual all the information that you know, that you've assessed around that nature of risk, around their ability to understand the information you've given them? Have they retained it? Are they weighing that up? Not simply, are they communicating a decision by saying, do one? All of those things really matter, because as clinicians or as practitioners, you have to be satisfied that your statutory duty of care has been met, and that means complying with obligations under the Mental Capacity Act. So exploring with them simple questions like, do you understand why I'm worried about the risks you're facing, will help you understand not just their perception of the risks, but also whether they have executive capacity to act on what you're proposing needs to happen. And those are the critical areas around capacity that really do make such an impact when it comes to keeping people safe. Apologies if you hear quite a lot of noise in the background. I've got 3 kids who have decided to now is the time to do their piano practice and to run up and down the stairs, but sorry for that. Empowerment, the 6 safeguarding principles. The first one being empowerment. What we talk about and what we mean in this context is that you are looking for supporting the individual in line with your legal obligations to assess or to carry out an inquiry in a way that enables them to understand the risk, that enables them to be involved in that decision making. And if they can't be involved in that decision because of a brain injury, because of substance misuse, because of all sorts of issues that might come into play, then there's a statutory obligation for the local authority who leads on safeguarding inquiries to consider appointing an independent advocate, independent of the local authority, independent of the assessors or those carrying out the inquiry, to support and act as a voice for that individual. And this is a really critical piece of legislation. This is a really critical safeguard for individuals. It means that there is somebody speaking on their behalf or thinking through the plans and working through the plans and ensuring that they meet the obligations, but also that they're taking into account the individual's own wishes, experiences, and that will really matter, particularly where you've got a situation of, say, somebody who's trusted by the individual, who can act in that capacity. So that's a really important safeguard, but we've seen it dip. We've seen the use of advocates really dip over the COVID lockdown. And so it's really critical. Again, all of us as practitioners can say, and so who's the advocate in this case? If they're not involved in this discussion, who's advocating for them? Are they independent? And making sure that person is brought in at each time, at each meeting, or if they're not brought in, that they have an advocate at each meeting, each discussion is really important. Prevention is another core duty, a core principle within safeguarding, talking about it being proactive, and I've already kind of covered that, but thinking about kind of, what access do you have to the case history, thinking about what you could be reasonably expected to know, how you use that to inform your actions, or and basing that around your duty of care is really critical. And feel confident in your role. It's okay to use assertive outreach, or you think about trusted assessors. Some of the most impressive work, I worked with Voices of Stoke quite a bit actually last year and the year before, working with some of their really kind of, cases that had just got stuck. And the thing that really unshifted that was their advocates, their staff being used as trusted assessors, as go-betweens, because they were trusted by the individual who didn't necessarily want to be in the meetings, but they wanted their voices heard. And provided those individuals, those workers, were able to be supported and go back to clinicians or to other professionals and say, okay, so how would we solve this? Or what can I offer in this situation? And they've got the backing of that cohort, that team around them, that really made a big difference. So using trusted assessors is perfectly lawful and really, really to be applauded. Use your safeguarding information sharing protocol if you have to, or escalation protocols if you really get stuck and you can't get past the computer says no. Proportionality is so critical. It means that being that inquisitive, but equally understanding that there is a balance always in safeguarding, that sometimes not acting is safer than you know, than using a sledgehammer to crack a nut. You know, that actually, if it's going to breach that kind of trusted therapeutic relationship, then perhaps you need to think of a different way of doing that. But you'll need to maybe own that risk, but also share it across the agencies and make sure that your organisation is comfortable and confident around sharing that, and that they've got your back at the end of the day. And protection is also a critical core principle. So not thinking about it from the point of view of, well, we can't do a safeguarding inquiry because we don't have a service to offer. That is really the wrong way around. But thinking about actually, if the criteria is that an adult with care and support needs in the area at risk of abuse or neglect and unable to protect themselves, that duty is then triggered. What you do in terms of section 42.2, i.e. what should we do about this and who should lead, it can be discussed across the multi-agency, but it's really critical that we are working proactively to think about protection. And the mayor's case is really strong. Here the individual had capacity. He wasn't homeless as such, but had faced very significant risks. And in this instance, the council kind of had tried everything, and everything had sort of never worked, if you like. And they kind of went to court to say, you know, have we done enough? And the judge just said, not whilst you still have safeguarding responsibilities. Go back and try again. So remembering that ongoing duty under section 11.2 of the Care Act, keep assessing, to keep offering support, continues if there is a risk of abuse or neglect, even where the person has capacity. And there's just a little addendum there to the Homelessness Code of Guidance, which sets out that there is a requirement now to consider clinical vulnerability for COVID-19 to anybody with a history of rough sleeping as one of the things that might trigger priority need. Final two, partnership. I'm going to speed up. Partnership and accountability. I've given you details there, but never forget that reciprocal duty to refer. It's really wide and it's really important in those kind of key areas that I've talked about there. And that duty to cooperate across agencies. That's a statutory responsibility for relevant partners. And I've listed them there. So it's critical that we use that in a really proactive and positive way. I have lost my there. Finally, you can read this at your leisure, but I just wanted to kind of give you the link to the toolkit, where I noticed somebody had put it in the chat earlier as well. So thank you for that, whoever that was. And just remember that this is just a prototype for testing. We're still welcoming of comments or suggested improvements, so please do send them our way, because it is a work in progress. This, thankfully, is an area that constantly evolves and we're constantly getting better. So I think it's really, really important that if you're finding parts of it impenetrable or unhelpful, do tell us, so that we can work with you to improve, constantly improve it too. I hope that was a quick run through and useful, but I'll stop sharing my screen now and I'll check the chat for any questions and then hand it back to Nigel.
Perfect. Thank you very much indeed. That was absolutely fascinating and kind of really exciting. You know, when you've been working in this area for as long as much of our audience have, to be reminded that now with the section 42 responsibility, there's no ordinary residence requirements, there's no threshold of significant harm, and making safeguarding personal. Those are all really important and exciting developments. So really pleased to hear that stuff, and I've got some questions already. What I'm going to propose is that we take all the questions at the end of the three presentations and share those around. And certainly, if people have got questions, do remember, please, to put them in the chat. So we're now going to go on to hear. Thank you, Fiona. We're going to go on to hear from Kendal Beasley, a homeless specialist nurse in adult safeguarding at East Kent Hospitals Foundation Trust. Kendal isn't using slides, so that makes life simpler. So I'll hand over to you now, Kendal.
Thank you, and thank you for inviting me to speak. It's very exciting and a little nerve-wracking, but yeah, no, it's very exciting. So my name's Kendal Beasley. I'm homelessness adult safeguarding practitioner. I was appointed last year, September last year, to sit within the safeguarding team. Very forward-thinking safeguarding lead, and one of the senior safeguarding nurses, Nikki Tanner, who is known within the faculty, I believe, they identified that their wish list, they would like a homelessness safeguarding nurse within their team. So when I joined the trust, I think it was certainly anecdotally aware within the trust that there was an issue potentially for individuals that are admitted that are homeless, and what did the trust do? How did the trust help the individuals when they were admitted? And my investigation found that the plan was that individuals would, once the discharge date came, then they would be put into a taxi to the local authority, and that was the discharge plan. So I have been, I work across the trust. It's quite a big trust, and big thing to sort of get out and let folk know about me and consider what we can do, what the staff can do in relation to assisting individuals that are admitted that we do identify as being homeless. So the identifying homelessness, asking the difficult questions, supporting the staff with within the legislation with the duty to refer, making sure they've got access to a GP, referring to drug and alcohol services, ensuring individuals have a mental capacity assessment, referring to the mental health services, and looking at individuals, and with that safeguarding envelope there, with that safeguarding encompassing the safeguarding. So considering self-neglect, considering are they at risk of abuse and neglect, and if so, encouraging the staff to complete the CASAF, the referral form to the local authority. It's been interesting and a massive journey, and making links within the hospital and supporting the staff. There's lots of positivity from the staff. They want to do the right thing. They want to help, and they're aware of me now, and I get lots of phone calls, and it's amazing. But linking with the multi-agency teams, so looking outside of the hospital, we can identify the issues within the hospital and support, but we can't do that in isolation. We have to be part of the bigger team. So thinking about the issues when we come to a discharge date, thinking about trying to extend the stay, we're trying to avoid, and I'm trying at all costs trying to avoid a street discharge. But if that's the option that potentially we're going to have to go with, can we delay discharge so that we can keep the individual safe and help them recuperate for a little bit longer? Asking the difficult questions with the individual and making the safeguarding personal, MSP. So putting the individual at the centre. What do they want to do? How do they want to approach it? Asking what they want to happen. Where will they go when they are discharged from hospital? Identifying homelessness quickly is really difficult. We've had a case where a lady was admitted to the ward, and she'd been in for 3 weeks before the individual. They thought, bless, because she wasn't communicating, they thought that it was mental health issues. But actually, when I went to have a chat with a colleague, she was embarrassed to say she was homeless. The stigma attached to saying that she was homeless. So encouraging the staff and empowering them to ask those hard, difficult questions about where will individuals go when they're discharged. The encouraging staff to think about the 6 principles of the adult safeguarding, so the empowerment. So we want to put individuals at the centre of the decision making, and this is a whole new concept for an awful lot of them, because they've not had that question. What do you want to happen? And it's often met, it's been met with a little bit of, oh well, have I got a choice? Is it down to me? And it's supporting those individuals, but supporting the staff to that we can do something. There are things we can do to help. It's not a question of, that's it, we've done our bit within the acute service. It's looking at the individual as a whole. The prevention, trying to avoid this sort of continual cycle of individuals, they're admitted to hospital, they either take an early discharge because they feel that they're not being supported, or they're not understood, or their needs aren't being met. So from the drug and alcohol point of view, if they're not supported with their substance issues, mental health, trying to engage them with services with their consent, but making them central to what's happening, and sharing the information with them as to what they can expect, because many individuals, they're so used to being, they don't have a voice, they're not visible, so that it's really great to be able to empower them and to give them that confidence and to put them in touch with services. Proportionality, obviously we're not going to take over, the individual needs to own it themselves, so supporting them to do that. And protection, absolutely, it's folk who have been disempowered, they haven't got the voice, they need us there to sort of help guide that and to help with the protection, and to ensure that the right agencies have been are part of the journey with them to take it forward, bringing on to partnership, and then the accountability. I've had really good, in the short space of time that I have been in post, it's been an amazing response that I've had from hospital teams, hospital staff. The biggest shock has been that prior to me being in post, the numbers weren't being collected, and I've managed to liaise with the IT systems within the hospital, and so anyone that comes through the doors with a ZZ99 postcode, I get an electronic alert to let me know that they're in the hospital. I'm focusing on individuals that have been admitted, and so far every week there's between 10 and 15 people across the trust who are homeless, who've got complex needs, working in real close collaboration with the local authorities and the local charities, local providers, daycare centres and such. I think the biggest sort of wake up really is the amount of folk that I have been referred, that I'm aware of. And since November, since starting to collect the numbers, I've got nearly 500 people on my spreadsheet, and some of those are repeat. So not all of them have been admitted, but they're frequent attenders. So again, there's more work in the future. I know where I want to be, and it's going to take time, but from little acorns and all that. So just really from a safeguarding and a homeless perspective within the hospital, encouraging staff to have the confidence to engage with the conversations, because often they don't feel confident, to try and address some of the stigma that staff have, individuals, they choose to be homeless, or that's a life choice. Ask them staff to consider about the day-to-day survival of an individual that finds themselves to be homeless. Consider brain injury as well. We're aware that great many folk that are homeless have experienced or have sustained a significant brain injury, and with that comes the sort of the thought process, their capacity, and the frontal lobe damage. I'm flying through my notes, I'm sorry, because I don't want to. So supporting staff with duty to refer and referring to GPs, and it has been awesome, actually. It has been awesome because local authorities, it's a big organisation, it's a big trust. I thought that initially I was only dealing with 5 local authorities. Today, I think there's 12 now that I've been dealing with. All of them have got a different way of interpreting homelessness reduction, and that's a real challenge. But super. You know, they've got a lot of them have got rough sleeper teams that I'm working collaboratively with, and they're on board, and it's just going to get better. I think that's it. I think I'll so yeah, but thank you for giving me the opportunity to share where we are. There's lots more to do.
Fantastic. Thank you, Kendal.
Oh yeah, sorry, I was just going to say that I have within my role as well. So I've been recently involved in the SAR side of the safeguarding, and have been aware that Oxford are proposing to investigate every homelessness death and have that as a SAR. And I've actually, that's been one of my recommendations within my SAR report. So
what's a SAR?
It's a safeguarding adult review.
Okay, so everybody will get one of those for a homeless death, the death of a homeless person. Oh.
That's yeah. I mean, that's not my original thought. That was Oxford are already doing that. So yeah,
exciting stuff. Fantastic. Thank you very much. And you're all being very good at keeping to time. So now we're going to pass over to Shona. I'm hoping Mo is going to be able to bring the slides up for Shona, and then she's going to do a Chris Whitty next slide, please, to move them along.
Thanks, Nigel. I'm going to turn my video off now as well, because I have very temperamental internet connection today.
Fantastic. Well, there seem to be some slides up there, so that's exciting.
We go back to the first one, please. Thank you.
Off you go, Shona. Thank you.
So, hi everyone, I'm Shona. I'm the homeless specialist nurse, part of the safeguarding team at Gloucestershire Hospital's NHS Foundation Trust. I have been in post now for 18 months, I had to think then. Before this, I was a staff nurse in the emergency department, where I undertook a quality improvement project looking at homelessness in the ED. It was this project that led to the creation of my current role. Fiona's presentation has covered a lot of the duties and powers under the Care Act, and as time's very short, I'm just going to give a quick look at some of the challenges and approaches in putting the theory into practice and safeguarding homeless people in the emergency department. All hospital admissions should be utilised to assess and support homeless patients in regards to mental health, substance use, physical health, care and support needs, and to ensure that safeguarding concerns are acted on. But how do we ensure the same approaches are used in the emergency departments? Emergency care is fast-paced, time is limited, with many barriers to holistically supporting homeless people on discharge from ED, such as we cannot remove the risks, lack of time, what is the point, they'll be back tomorrow, I don't know who to contact, it's a lifestyle choice, and we treat the emergency, not the person in the emergency department. These are a few of the comments, oh sorry, back one. These are a few of the comments from staff while undertaking the quality improvement work in the ED. Many of you are going to recognise this as poor practitioner attitudes, which can lead to missed opportunities, which leads to safeguarding concerns not being acted on, as evidenced by many safeguarding adult reviews. Next slide, please. In the last 18 months, the focus has been on collaboration, encouraging professional curiosity, the creation of simple pathways. A&E is fast-paced, limited time, limited resources. They don't have time to refer to multiple agencies. Any pathways implemented should realistically take into consideration service demands. Following a lot of PDSA cycles, our homeless patient pathways can now be accessed with just one phone call, making it much easier for staff to complete in A&E. Focus on multi-agency working, and just to highlight what Fiona and Kendal have already said, really, that multi-agency working outside of the hospital is so important to supporting people on discharge from hospital. Information sharing. If somebody is at risk of abuse, harm or neglect, we have a duty to share the information to reduce that risk. As long as the information is proportionate and necessary, we're okay. Share the information. Empowerment, and that's for staff and patients really. Lots of teaching on trauma-informed approaches, challenging cultural perceptions. Capacity, one of my personal favourites. Many of us will have seen those words, well, they have capacity, documented or heard those over the phone. That's awesome. What have they got capacity for? Capacity is decision and time specific. Somebody may well have the capacity to make decisions around their accommodation. Brilliant. Do they have the executive capacity to manage a tenancy? Can they manage their utilities? How are they going to live independently? What is their capacity in regards to that everyday living? And also, it's just recognizing that as a support need and ensuring they get that care need assessment if needed. Also, a lot of emerging research on childhood trauma and the impact on the brain, and ultimately that person's ability to protect themselves safe, to keep themselves safe from harm, which is all very exciting. Social assessments. Do you have somewhere safe to go? Again, the emergency department, that there isn't much time. We can't expect brilliant in-depth social assessments. So just that focus on, do you have somewhere safe to go, to highlight any sort of like needs before discharge. Next slide, please. Following service development and the creation of the referral pathways, we now have access 24/7 into emergency accommodation direct from the emergency department where that's appropriate. We do have some people, you know, where the risks are too high and they can't be placed in the emergency for some reason. All of those people that present to Gloucester Hospital that are in that situation have an individual management plan, and I liaise direct for the other agencies involved. Every single homeless person who attends the emergency department will be referred to the safeguarding team for review. And then I make ongoing referrals based on the risks, consent of the person and the person's needs. And this process over the last 18 months has found many who self-neglect, victims of human trafficking, people that are using sex for rent, sex working, victims of exploitation. We've uncovered county drug lines, victims of gang crime, victims of modern day slavery, many that have cognitive impairments and brain injuries. All of these things are safeguarding concerns. Those people are at risk of abuse, harm and neglect, and we must be safeguarding them. Nobody walks into an emergency department and says, right, so I'm a victim of human trafficking and I'd like some support, please. It takes good staff attitudes, patience, kindness, and a really good degree of professional curiosity. Next slide, please. The risks of abuse, harm and neglect homeless people are subjected to has become so normalised to some extent in British society. The safeguarding of homeless people does not provide a magic solution, but it does encourage the multi-agency response often required to holistically support and mitigate those risks, leading to positive outcomes and a better quality of life. Homeless people face some of the harshest inequalities in accessing healthcare. Emergency departments can play a vital role in reducing the long-term social exclusion homeless people face. The clinicians in ED may be the only professional that person has contact with. We must make every contact count. Now, I really rushed through that. I'm really sorry. I thought it was going to take me a little bit longer. Did I do that thing where I talk really fast?
Sounding fine to me. Thanks, Shona. That's great. So if we could stop the screen sharing. And Shona, did I hear you say that every homeless patient attending your emergency department is referred for a safeguarding review?
Yeah, so I'm part of the safeguarding team, obviously. We've created, on completion of the referral pathways, I've then created a homeless patient checklist. So every person that comes into A&E is now identified on our electronic system, and NFA is put next to them, and then a homeless patient checklist goes into that patient's notes for triage. But also I get an alert as well. I get a report that's live. So when somebody comes into A&E, I will find out. So on receival of the checklists, A&E just have to make the one phone call to initiate that emergency accommodation. And then our P3 hospital in reach worker will come to A&E, assess the person in A&E, and then take them to the accommodation, or out of hours, it's done via our emergency duty team. And then the following working day, I pick up. And it's amazing the amount of people that A&E have just ticked a box saying, yes, they're homeless, please look at it. They've gone, to the travel lodge or somewhere for accommodation. And then actually I'm looking back through things and going, oh, well, I'm concerned about this thing that happened a few months ago. And you connect all these dots, and just that professional curiosity. And actually that person's being exploited in a household and force-fed drugs, or we're seeing a lot more exploitation than what, and like I said, you don't see that in A&E. Nobody walks in and says, I'm being coerced into sex work. It's the safeguarding aspect of that investigates it. And we've picked up so much that I just think if this process wasn't in place, would be missed. And again, those multi-agency sort of like, it might be, oh, I recognize that name, they were brought up at a meeting a couple of months ago, and it's just all that background kind of things that you don't even realize you're absorbing, but then putting together all those little bits of information, and actually when you ping it all together, really paints a picture of somebody that is at risk of abuse, harm and neglect. Quite often we can avoid the section 42s just because I can initiate the multi-agency response to protect that person before it needs to go to a section 42. But sometimes, you know, I can't mitigate those risks, so we'll take it to a section 42. And like I say, safeguarding is not the magic wand, but it does provide that platform for working together to keep people safe.
That sounds absolutely extraordinary. That emergency accommodation out of hours, who's paying for that? Is that housing or is that social care?
It's housing. So again, it was one of those things 18 months ago, it took some working through to create these pathways. Lots of local authorities. I work across 6 different local authorities, so everybody approaches things quite differently. But again, it's just working through that. A&E don't have time for online referrals. They don't have time for lots of phone calls. How can we make this work? We did a month's trial of the emergency duty team placing people in hotels direct from A&E. And then we reviewed it at the end of that month, and it had worked really well. We need to catch people when they're new to homelessness. If they come to A&E and say, I'm homeless, I'm new, you know, I've had a relationship breakdown, life's got on top of me, whatever the reason, we need to have processes in place so that we can pick that up and support right from the first moment. We don't want somebody to turn into drugs and alcohol, or, you know, 24 hours on the street would be enough to tip me over the edge. You know, it's recognizing that and having processes in place. Doesn't work all the time. There are risks involved, but what we have found is that the benefits outweigh the risks, and we're able to work with those early on homeless people much quicker.
Brilliant, thank you very much indeed. That's fascinating. Just imagine if we get every emergency department in the country to work like that, wouldn't that make a difference? So we've got about 5 minutes for questions. I see, Fiona, you've got your hand up. Did you have a particular comment you wanted to make?
Just a very quick one. I can completely understand why people wouldn't necessarily want to go down a long bureaucratic process, and section 42 for many people is considered a long bureaucratic process. Just a quick shout, it doesn't have to be, but what is critical for people like me and on the safeguarding board is to have that evidence base, that data, and if it doesn't get recorded as a section 40, as a safeguarding incident, it falls off the radar for us. So we end up having to rely on things like safeguarding adults reviews, i.e. the person has to have died or been seriously harmed. So my plea would be, if you've done that intervention that has protected an adult with care and support needs from abuse or neglect, get it recorded as a safeguarding.
Yeah, there are. So we are in the process of moving towards the sort of like integrated care system now. Obviously, I'm safeguarding within an acute trust at the moment, but I will soon be part of kind of the wider safeguarding team. There's been lots of conversations and interest in an exchanging of data that's led to this point, but it's all really exciting and a lot of support.
And if there's anything we can do to kind of make it less bureaucratic, just tell us, because that's the really critical thing. It's got to be easier for practitioners in order to overcome those really those barriers we all know. Thank
you. Kendal, you're waving?
Yeah, I was just going to say that I very cheekily raised a section 42 safeguarding alert and copied and pasted the elements within my referral, because the individual I had in mind actually ticked all of them. We didn't get a section 42 inquiry. We did have multidisciplinary team meeting though, because it got their attention. So it was, yeah.
Fantastic. That's really helpful. Thank you. So I got a question, I think primarily for Fiona. You mentioned assertive outreach, trusted assessors. How do you get that status? Is that something that somebody has to give you, or can you just claim it for yourself?
So it depends on how bolshy you all are, but so and how, you know, how pragmatic the approach that's taken. You know, sometimes it just needs one good person in an organisation, as Shona has found, to kind of go, this would be better. But the more we talk about it, the more that we kind of say, look, you use it all the time in discharge to assess. You do. That's a standard process. Why is it different for this cohort? Because they don't have someone somewhere, an address to go to. If we know these people well, if we know this this risk and this level of need well, then why wouldn't you use this information that we have? It can't be lawful not to. It's completely irrational not to. So from a public law perspective, that's how I would frame it.
Perfect, thank you. I've got a couple of hands up. We'll go to Peter Buckman next, please.
Hi, just two sort of thoughts. One is, I wonder if we would be lynched in a busy London A&E if we did a safeguarding for every homeless, or asked for a safeguarding to be done for every homeless person. I'm just wondering how that could be made to work and to be collaborative with social services rather than a point of antagonism to both A&E and social services. So that's one thing. And then the other, I'd put in the chat that often, particularly with abuse and things like financial abuse, when we suggest raising a safeguarding, the response we often get, because often, times the person says they don't want to pursue it because they might feel under duress, and whereas it's quite straightforward in safeguarding children that that you don't need to say please refer me to safeguarding. We seem to get often the response back that if the person doesn't want to have the referral done or doesn't want to cooperate with it, then it's kind of closed almost immediately. And is that right? Well, is that how it should be? And if not, then how do we challenge that?
Can I quickly answer that? I tried to answer it in the chat, but it got lost in the conversation. It's so difficult. It is really difficult. It's obviously best to have the person on board and want to deal with it. But like you say, they're very likely under duress. They're very likely, being coerced, and that's why they're experiencing financial abuse. So it's not always safe for them to be. So as with children, if there's a safeguarding risk, definitely do it. As Kendal said, when you copy and paste, these are the criteria, this is how they meet them, this needs a safeguarding response. But also if you do it in the context of, and if we don't deal with this now, the likelihood is X, Y, and Z, and the escalation of need, we will be dealing with this later, but at a much greater. Shona was very clear about the level of exploitation that she's picked up on by just asking those questions. So absolutely challenge, but equally, that's why local boards will have escalation processes. So if you get a computer says no, you can say, could you take this to your head of safeguarding, because we are really concerned. And this is the third time we've had a no, or this is the fourth time. This practice has to change. Otherwise we keep seeing this person, or you'll see them and they'll reach a soul. And that tends to focus people's minds. If you can, if we can have that in writing, because that could, we'll need to explain why it didn't go further if this ever becomes, meets the criteria for a safeguarding adults review.
Fantastic. I do love that.
Passive aggressive, but that's the lawyer in me, I'm afraid.
Can I answer the A&E one? And just to second what Fiona has said, yeah, be aggressive. Absolutely be aggressive. Okay, fine, close it, but this person may die. What name would you like me to put on my records? As far as A&E goes and safeguarding, absolutely, it would need to be an additional resource. We can't expect our current safeguarding teams to suddenly start safeguarding all homeless people. I believe the lovely commissioner who commissioned my role is actually involved in this course. So maybe you could tap him up for some advice and resources on how's the best way to sort of encourage safeguarding teams to take on a role such as this. It's not something that could be done by a safeguarding team. It's just too much work to be shared, I think, among a team.
Fantastic. Well, brilliant models to be shared. We've got time for one more question. Shushrat Jadev has got his hand up there.
Yes. Hi, Shona. Congratulations for managing to swing this. Two specific questions, and I hope you don't mind my asking. One is, which A&E is this? Is it one or is it two? And can I send my patients there?
Absolutely. So I work for Gloucestershire Hospital's NHS Trust, and we have two emergency departments. So sort of like all of the policies and pathways cut across both areas. So we've got kind of one process for Cheltenham and one for Gloucester, but I cover both emergency departments. Wonderful. And yeah, send them all. We love them. Yeah.
I'll charter a bus.
As somebody who did a safeguarding adult review where people were put in taxis and sent across borders, it's not great practice.
Especially busloads coming out of London. Yeah. Right, so we are getting nearly out of time. Shona, there's a question in the chat which may about repeat offender attenders, which maybe you could answer in the chat. I just want to hand over to Alex Bax because he had a couple of messages from Pathway.
I mean, thanks, Nigel. A fascinating session. And yeah, thanks, Shona and Fiona, everyone. Really inspiring to see what can change. So yeah, amazing. I love the answer to Peter to get more aggressive. Just a couple of very quick notes, just looking way to the future. Many colleagues on the call will have come to our conference this year. We've just booked dates for next year's faculty conference. So really, really early warning. 16th and 17th of March, 2022 will be the 10th Faculty for Homelessness and Inclusion Health International Symposium. Please start sharpening your pencils and thinking about the papers you want to write and present. And or if you've got topics or ideas you want the program to cover, please email me, email Nigel, send them in to us however you want, so we can go and find, if there's a topic you want covered and you don't know who should speak about it, set us that challenge to go and find the speakers to bring you what you need in terms of information.
I'll start to panic now then, shall I, Alex?
Yep. Jeff's on the organising committee too, so that's going to be his job. And then one other thing, just a nice thing to share, we've been nominated by something called the World Doctors Orchestra to have 2 benefit concerts played for us. And again, we'll share this through the mailing list, but they will be on the 3rd and 4th of October. I'm not sure what I think of this, but it'll be a whole orchestra composed of doctors. Is that scary or good? Anyway, one in Bury St Edmunds and one in London. So please watch out for it. And if you can, do come along. I'm not sure whether they'll be online, but it's lovely to be honoured by them as choosing us as their kind of beneficial charity. So really nice. COVID dependent, of course.
Brilliant. Thank you, Alex. And it's like psychotherapy, you get all the good stuff in the last 2 or 3 minutes before the end of the session. So just will conclude by thanking each of our speakers for fabulous and fascinating presentations. Thank you very much to Fiona, Kendal and Shona. Thank you to all of you for attending, and look forward to seeing you at the next faculty meeting. Thank you very much. Goodbye, everybody. Thank you.